I am vice chair of research and professor at New York University in the departments of OBGYN, population health, and the Division of Medical Ethics. For the most part, except potentially in the case of trans women on hormones, you're not going to get any different medical care because of your sexual orientation or your gender identity, but you should get different psychosocial care. And that's what I think a patient might need to self-advocate for, to find out, what resources on the team, because it's not always the physician that's handling that point, but pointing them in the right direction to social work, to nursing, to support groups that are relevant for what they're disclosing. We train clinicians to expect. People are angry or scared anyway with a cancer diagnosis, regardless of anything else, but coupled with feeling that there's some sort of stigma associated with who came with them, or how they're dressed, or how they're presenting, can make for a really upset, anxious patient by the time they meet the doctor, who then has to overcome all of those fears related to the care that they've got just walking in the door, or the treatment that they got. And then also try to focus on what the cancer plan is. I've heard staff ask patients, do you think you got prostate cancer because you're gay? Just like sadly, people with lung cancer, they say, is it because you smoked? Not everybody who gets lung cancer smoked. Some people never smoked. Some people quit a long time ago. If someone has a heart attack, we don't say, did you eat a lot of red meat? So people are often looking for reasons to separate themselves. So I won't get that type of cancer because I don't do that. But really, cancer can happen to any of us, even with the best of efforts, and comes with aging. So the things I've heard that make me angry are when people try to blame or give a reason for the cancer as if it's related to a behavior. Another thing that it doesn't make me angry so much, it just makes me sad, is trans women who don't identify with the prostate, for example, in their body, and are not getting it checked regularly. Even if they've had gender affirming genital surgery, the prostate is not likely to be removed. So it's still present. And the anxiety and the trouble that they experience, I've only seen this 2 times, in finding a provider who knows how to examine them and knows what a prostate should feel like in the body of a person with a neovagina. And it's scary enough to have cancer and scary enough to get care without having to search for a provider who knows how to give you, unique care. The other things that are off-putting are just kind of general remarks, maybe about 2 men or 2 women, entering together, and the assumption being made that that's someone's brother or sister rather than their romantic partner. If they say, this is my husband, if a man says, this is my husband, and then the nurse says, your friend can't come back with you, like not acknowledging the relationship that was just disclosed. There is also patient bill of rights, and those should be very present in all areas of a hospital or a doctor's office. And any form of discrimination or stigma is usually contra to the patient's bill of rights, and you can refer to those. There's also patient advocates in some hospitals. You have a right to make sure that nothing is in your medical record that you don't want to be in there. You have a right to say who can and cannot visit you, and I only want these people here. So, exercise those things, because it makes you also feel like you have some sense of control. And oftentimes with cancer, we feel like we've lost control, over our bodies, and we try and take control in any way we can, through diet or exercise. But those are some other ways to kind of take control. If your care provider or part of your care team makes a mistake in some way, calls you by the wrong pronouns, by the wrong name, mislabels the person who's with you, don't assume that they did it on purpose. Most of us make mistakes on a daily basis, and we want to be corrected. I have trouble pronouncing people's names. They tell me that their name is Richard, and I say Rich, and they say, no, Richard, that's the name that they want. I want to be corrected, and I want to make a note to myself, and I want to ask you, what's the phonetic way to pronounce your name so I get it right the next time? So if, however, you correct them and it keeps happening, then there's a problem. And I think over a period of time, if you're not feeling safe with the care that you're getting, go someplace else. You want to go someplace else anyway with cancer. For the most part, you want to get a second opinion. Most good clinicians will encourage you to get a second opinion, and weigh out if you feel more comfortable in one environment than another. We often tell people, you cannot just put a rainbow flag in your window and that means that you have welcoming spaces for the LGBTQ plus community. The staff have to be trained. There has to be all gender bathrooms. There has to be a patient bill of rights policy. We don't like to talk about when cancer care is not effective, but it's really important, I think, for people in same-sex relationships for planning end-of-life care. Something that we learned, for example, that if you might have to legally adopt the children of your partner, or your partner might have to legally adopt those children. You can't always assume that in the event of the death of one parent, they will go to the other parent, even if they're on the birth certificate. So it's another important reason to find out who a patient support person is when you're planning palliative care. So all of those things can be thought about and addressed, which hopefully no one ever needs, but the reality is sometimes they do.